Chairpersons, ladies and gentlemen, at the outset, I would like to thank Dr. Arun Garg for not only inviting me here, for his organization skills, and for his profuse hospitality. The focus of my talk is on a comatose patient in the ICU. The plan of my talk is to discuss the pathophysiology of consciousness, clinical approach to deteriorating level of consciousness, neurological examination in a comatose patients, how do you give a prognosis and long-term outcome, and just the principles of emergent therapy. Now, in this era of improved resuscitation and ventilation, it is not common for a practicing neurologist to be confronted with a patient with a deteriorating level of consciousness. And it is a taxing problem because time is of essence. You have not put the timer on, please. Put my timer on. And please, I've got 40 minutes, not 16. Yeah, don't worry. Because I like to stick to time. If you give me 16 minutes, I'll stop there. So time is of essence, in which you have to make a prompt diagnosis, order appropriate investigations. You don't have the liberty to cast a wide net. Then start the appropriate treatment. And one of the main armamentum of a neurologist, which is history, is often not forthcoming. Now, before I go on to loss of consciousness, let us see what is consciousness. Why is it not moving forward? The slides are not moving forward. Okay, sorry. No? Fine. Now, consciousness depends on two factors. One is arousal, and the second is the content of consciousness. Arousal is the act of waking up from a deep sleep, and it is linked to a group of cells in the rostral brainstem, which is known as the ascending reticular formation. And these cells project to the diencephalon and to both the hemispheres. The content of consciousness, put very simply, is awareness of self in the environment. And every day, we go through this cycle. When we get up from a deep sleep, we first arouse. For a fraction of a second, sometimes we are disorientated, but then we get orientated where we are. Now, the content of consciousness is the integrated function of all the cortical neurons in both the hemispheres. Therefore, consciousness basically is an interplay between the function of the ascending reticular formation in the brainstem and both the hemispheres. Please bear that in mind when we deal further. Now, this can result in three states. And I would request all the postgraduate students, whenever you go to see a patient in the ICU, you should ask yourself these three questions. Is the patient awake and aware? Which is the normal situation, except in the locked-in syndrome, where the patient is awake, is aware, but totally paralyzed below the levels of the eyes. The second situation is the patient awake but not aware. And I'll tell you what the conditions are. And the third, which is the focus of my lecture, is not awake and not aware, which is stupor and coma. Now, when a disease process affects the level of consciousness of a patient, it is judged by cognitive function and motor function. In the earlier stages, the patient sleeps excessively. There's hypersomnia. Then there can be an acute confusional state or delirium, or there's a severe cognitive disability with akinetic mutism. But sometimes these conditions don't come in a sequence, they arise when the patient is coming out of the coma. If the disease process is further severe, it results in stupor and ultimately in coma. If the coma is very prolonged, it results in brain death. If the coma is less severe but prolonged, it may result in a PVS, persistent vegetative state, or minimally conscious state. And sometimes when the patient is emerging from coma, the reverse cycle takes place. Fine. Now, if the patient is awake and not aware, it is an acute confusional state, delirium, akinetic mutism, minimally conscious state, or persistent vegetative state. Okay? In the interest of time, I won't go into the depth of these things. So, coming to the main focus, if the patient is not awake and not aware, in the earlier stages, it is stupor. And it would be best for you all to assess the patient at this stage, come to some conclusion, and start therapy. Now, this stupor resembles deep sleep. The patient responds to vigorous stimulation, but with limited motor activity. He may localize a supraorbital painful stimuli and go for your hand. Once the stimulus ceases, he lapses back into the sleep-like state. And this is really a pre-comatose stage. The main differential diagnosis is psychogenic unresponsiveness. And on a clinical basis, the main things in psychogenic is you get a certain amount of resistance when you try to open the eyelid. Okay? The second thing is there is an absence of any physical signs in psychogenic unresponsiveness, whereas in stupor, physical signs will be present. And you can do an optokinetic nystagmus, etc. I don't bother about ice cold calorics in EEG, etc., except if it is a medico-legal case and you want to document all your findings properly. In this day and age of litigation, that is the only situation in which you should do all that. Now, the patient is not awake and not aware, it's coma. Stupor has gone into coma. It's a state of unresponsiveness. The eyes are usually closed, but rarely you have open-eyed comas. But remember one, even if the eyes are open, there is no tracking and no visual fixation. The patient stares blankly. They cannot be aroused. There is no motor, there is reflex motor response. By reflex motor response, I mean there may be inflection. If there's further deterioration, there's extensor thrusting, and ultimately there's total flaccidity with areflexia. If the coma is transient and severe, MCS, transient and more severe, PVS, and coma is very severe and irreversible, it results in brain death. Now, as I mentioned, Consciousness is dependent on both the hemispheres and the brainstem. Therefore, in coma, the etiologies will be supratentorial, involving both the hemispheres. Therefore, it has to be a very large unilateral hemisphere or bilateral diffuse hemispheric abnormalities. If it's infratentorial, because it affects the ascending reticular system, a discrete lesion in the rostral midbrain can produce severe coma. And the cerebellum, lesions of the cerebellum compressing the brainstem can also produce coma. Now, if you look at the etiologies, the common etiologies are stroke, post-anoxic encephalopathy, poisoning, metabolic encephalopathies. Now, I think in this list, this article was written up to 2013, we'll have to put in autoimmune also. Okay? Some of the metabolic encephalopathies could have been autoimmune. But if you look at the African studies, you have CNS, and which is pertinent to India, you have CNS infections and epilepsy. Now, as I mentioned, why does the patient in coma deteriorate, stupor and coma deteriorate? That's because of cerebral edema with its associated herniation. Now, this is a cartoon. You have various sites, but the most important thing is rostral to caudal herniation of the brain. And if the lesion is more lateral, uncal herniation, and at times falcian herniation. If all the pathology goes on, it results ultimately in tonsillar herniation and death. Now, this one shows you that there's transfalcial herniation and also some amount of uncal herniation. But the transfalcial herniation is seen very well there in the PAT specimen. Here, there is a temporal lobe lesion, and therefore you see uncal herniation. And here you see it very nicely compressing the brainstem. All right? And here, this is the terminal event with all the durate hemorrhages and tonsillar herniation. Therefore, it is important for one to recognize the physical findings of early central herniation. This results in long cycle giant stroke breathing. The pupils may be small, but they are reacting to light, and the ciliospinal reflex may be positive. The oculocephalic maneuver and the oculovestibular reflexes are impaired but still elicitable. And patient responds in stupor by localizing a supraorbital painful stimuli, and in coma, they may respond reflexly with flexion of the limbs. If these patients are not treated or not recognized, the gravity of the situation is not recognized, they go further into a late stage. And there's hyperventilation or short cycle giant stroke breathing. The pupils may be mid-position or dilated. Don't expect every patient to have dilated pupils. They may be mid-position. And they are fixed. That is the important part. The reaction becomes sluggish, then they become fixed. There's a loss of oculocephalic reflex and oculovestibular reflex. And the patient initially responds with flexion, reflex responds with extensor thrusting, and ultimately flaccidity and areflexia. Uncal herniation, which is a slightly lateral one, and if you look very closely, here, it is affecting the crux of the brainstem. And the only cranial nerve which comes there is the third cranial nerve. So the signs are regular but rapid breathing. There is an ipsilateral partial third nerve palsy. The second thing is that as the midbrain gets compressed, there is an early loss of oculocephalic and ocular vestibular reflex. That is because the median longitudinal fasciculus gets compressed and is not functioning. So there is early loss of that. And there is unilateral or bilateral pyramidal signs. Now here I might say, okay, when you get a compression of the left side of the midbrain, you expect the right plantar to be extensor. But I would advise the postgraduate students and all the doctors, make a note of the opposite plantar. If the opposite plantar is initially flexor and then becomes extensor, please beware. Because the compression of one crux is leading to a compression of the other crux cell. So please look at the opposite plantar to the third nerve involvement and keep a monitor of that. If things go bad, then you get short cycle hyperventilation, you get an ipsilateral total third nerve palsy, and the rest of the features merge with central herniation. And by that time, I think it is sometimes too late to do any salvage operation. And you can see that in one of my cases. You will see that most of these cases have a CT scan. I don't rely too much on an MRI because it's very rapid and it gives me all the information that I need. Okay, now infratentorial lesions can be very discrete, and the important points at the early signs may be missed. So please question the caregiver or the person who's brought the patient whether he had imbalance just before he became unconscious, ataxia, whether he complained of some diplopia, some imbalance of gait, and then became unconscious. There is an early absence of the oculocephalic maneuver or the ocular vestibular reflexes. And as you all know, that the conditions that are there are outlined here. This is a patient who had a midbrain infarct. You can see it in the FLAIR, you can see it in the DWI, and also in the T2 weighted image. This patient remained in a coma for several weeks and then slowly, gradually came out. But this patient, again, as you see, it's only a CT scan, had a massive midbrain hemorrhage which outlines the complete midbrain. And he died within a matter of 4 hours. So, my point is, there are certain conditions which are very amendable to treatment. Not like this patient. But there are certain conditions which are very amendable to treatment, and I would like to draw your attention to them. One is a pseudotumoral cerebellar infarct. It is usually a large, complete pica infarct. And the initial symptoms may be non-specific to the cerebellum. There may be headache, or because there's compression of the floor of the fourth ventricle, there may be incessant vomiting. And that incessant vomiting persists. If you examine the patient, there may be ocular signs, which may be initially unilateral gaze or a sixth nerve palsy, or bilateral gaze, and because bilateral gaze is affected, there may be ocular bobbing, which Dr. Jaikumar showed you very well yesterday. The patient may go from drowsiness to stupor to coma within a matter of 24 hours. And in the earlier place, just remember that the CT scan is not the right modality for the posterior fossa and therefore can be normal in 25% of the cases initially. The important point to remember that the treatment of choice is a very simple neurosurgical procedure of suboccipital decompression. And if the patient is not operated, 85% of those who go into coma die without surgery. However, 50% have a good outcome even if they are stuporous. However, the surgical results are fantastic if you recognize this entity and the person is put up for surgery early in the. So you suspect it, and of course, naturally, you're going to go in for imaging after that. And these are some of my patients. The top left one, the gentleman who was drowsy with incessant vomiting, and he made a complete recovery and has gone back to work and making tons of money. Near top right is another patient, and bottom one is a cerebellar hemorrhage. All of them made very good recoveries, and you can see the temporal lobe, suboccipital decompression in them. The second thing that about the brainstem is brainstem depression due to sedative drugs or intoxication. The danger is of a premature diagnosis of brain death. And sometimes when you do the imaging of these patients, it is practically normal. So when do you suspect that this patient may have a drug intoxication? The first and the most important clinical point is that the pupillary and corneal reflexes are preserved out of proportion to the horizontal oculocephalic maneuver or the ocular vestibular reflex. Why is this so? Because this is a pharmacological knockout of the median longitudinal fasciculus. But it does not affect the pupillary reflex or the corneal reflex to the same proportion. Now, if you get these findings, you can do a confirmatory test, which is you elevate the head of the patient by about 30 degrees so that the lateral semicircular canal becomes vertical. And you inject ice cold water into one ear. Normally, when you do it in other patients, the eyes will get fixed toward the irrigated ear. But in this case, when there's poisoning and the median longitudinal fasciculus is knocked out, you will get upward deviation of the eyes. Now, the neurological examination of a patient in coma is restricted. You have to observe the patient. You have to elicit reflex activity and look at some of the brainstem signs. Okay? Now, the first thing is you observe the posture and position of the patient in bed. And that may tell you that he has a hemiplegia, simple things like that. But observe also for spontaneous movements. And I'll come to that a little later. The next thing you do is to observe the respiratory pattern. But let me show you that in the past, there were several types of respiratory patterns which have been described based on the level of the brainstem. But in this day of improved assisted ventilation, no intensivist is going to wait for all these respiratory patterns to emerge. Therefore, this exercise becomes superfluous. The only one pattern that I would request you all to observe is long cycle becoming short cycle giant stroke respiration. Now, once you've done that, then you have to test for neck stiffness, but please rule out fracture of the skull or the spine, cervical spine, before you do that. Now look for nosebleeds, ear bleeds, and look out for the battle sign. This is one of my patients with a battle sign. You can see that. It's a discoloration along the course of the posterior auricular artery with ecchymosis at the tip of the mastoid, which is very pathognomonic fracture of the base of the skull. And you can see that this patient is wearing a cervical collar. Once you've done that, you do a fundus examination and you look for signs of hypertension, signs of diabetes if you have not had the history. The comatose patient has just been brought by relatives or neighbors who don't know his medical history. So you look for signs of hypertension and diabetes, but also look for signs of subarachnoid hemorrhage. And this is a patient of mine with subhyaloid hemorrhage. And we made a diagnosis of subarachnoid. You need not do a lumbar puncture to confirm it. You can send the patient straight up to the angiography suite. Okay. And then you judge the level of consciousness, signs of lateralization, and brainstem activity. Now, I think this is the Glasgow Coma Scale. You all are all familiar with it. I won't waste time on that. Only to say, the peculiarity of the Glasgow Coma Scale is that even if you are brain dead, you might get a score of 2T, or you may get a score of 3. It's peculiar. Therefore, I prefer this 4 score, which is a full outline of unresponsiveness score. And that deals with the motor part and the eye part, similar to the Glasgow Coma Scale. But it also deals with brainstem activity using pupils, corneals, and in the terminal stages, the gag reflex. And it also uses the respiratory pattern. The first 3 respiratory patterns are not in an intubated patient, and the last 2 is in an intubated and ventilated patients, where the patient exceeds the ventilator rate and patient breathes with the ventilator rate. So this is a better, but it has somehow or the other not gained the popularity that it deserves. Okay, now this is my favorite slide. If you want to photograph it after I complete the animation. And I would request you to pay attention. If the patient has weakness, you all know, okay, there's a focal neurological deficit. But also check for grasp reflex and look for focal seizures, epilepsy partialis continua. They are very good localizing signs. Second, if the patient is plucking or clutching at his clothes, excited, the corticospinal tracts are intact. Simple observation. If the patient grimaces to a deep supraorbital stimuli, the corticobulbar tracts up to the pons or the facial nerve nucleus intact. If the patient has roving eye movements, it means that the median longitudinal fasciculus is intact and therefore the pons and midbrain are intact. If the patient has multifocal myoclonus, it's usually hypoxic ischemic encephalopathy, metabolic encephalopathy, or now autoimmune encephalitis. And the same is true for orofacial dyskinesias, metabolic encephalopathy or NMDAR. Okay, so just simple observations at the bedsides can give you a lot of knowledge. Now you can photograph it if you want. Done? Then I move on. Okay. Now brainstem function is judged by all the brainstem react. And all of you do it every time, so I won't waste too much of time on this, except to tell you that when you're looking at the pupillary reaction, also note the position of the upper eyelid and whether there is any edema or not, which may give you some idea of the etiology. Now, once you've completed the examination, you can roughly, after initial examination, you can roughly divide the patients into three groups: coma with focal signs, coma without focal signs but with meningeal signs, and coma without focal or without meningeal signs. The neurologist will be primarily involved in group 3. But this division is not sacrosanct. Let me give you an example. A patient with herpes simplex encephalitis will have neck stiffness. So, coma with meningeal signs. But he may also have a hemiparesis with uncal herniation of the temporal lobe. Second example is a patient with subarachnoid hemorrhage may initially have without focal signs but meningeal signs. At the end of 1 week, if they develop vasospasm and develop hemiparesis, then there'll be focal signs. So these three groups are not totally sacrosanct. For example, in toxic encephalopathies, you may get meningeal signs. So this is a rough classification for your thing so that you order the appropriate investigations. Nowadays, even before you go to examine the patient, the imaging is already done. Okay, now I can go rapidly through this. Coma with focal signs is stroma, infarcts, hemorrhage, tumors, etc. But please remember, I've been caught out once with my pants down with hypoglycemic hemiplegia. This was a lady who was admitted in coma. She was diabetic and had a habit of tippling a lot of alcohol. So all the attention was directed towards the alcohol. Imaging was done, found to be totally normal. And by the time I came up from the MRI suite up to the 19th floor of Jaslok Hospital, nursing staff had given her B1, B6, B12 because of the alcohol, and then they were supplying glucose. And with the glucose infusion, she woke up and the hemiplegia cleared up. Then the report came that her blood sugars, random blood sugar was 20 milligrams per deciliter. So I looked like a stupid fool. Her husband, who was a thoracic surgeon, without my permission, went and did a tracheostomy while I was in the suite, thinking that the coma will be very prolonged. And then, of course, he was very rich, thoracic. He promised his wife a nice emerald choker, which would cover the tracheostomy scar. So I've been caught out. These are MRIs, I don't have to go into that. I won't waste time. Now we come to no focal but meningeal signs. And if you have fever, it's meningitis or encephalitis. Without fever, subarachnoid hemorrhage or diffuse stroma with subarachnoid hemorrhage. Now forget the red flag. That is for me to remind me in the good old days when we did not have a CT scan. And if you do a lumbar puncture in that situation, you'll cone the patient. But nowadays, who will do a lumbar puncture without imaging? So forget about that. But rule out trauma of the cervical spine before you check out on neck stiffness. And this is one of my patients with pyogenic meningitis and a child at the bottom with saying post-contrast CT scan showing ventriculitis with abscess formation. Subarachnoid hemorrhage, anterior communicating artery aneurysm, and after post-coiling, good results. So we come to our bread and butter causes of coma. Anoxic ischemic encephalopathy, metabolic, and please put / autoimmune. Toxic encephalopathy, non-convulsive status epilepticus, drug intoxication or poisoning, and hypo or hyperthermic brain damage. But I would like to stress on non-convulsive status epilepticus. It is prominent status epilepticus without prominent motor symptoms. There's usually mild confusion to coma. It can vary. Negative symptoms may be aphasia, mutism, amnesia. And positive symptoms, which you must recognize, may be tonic eye deviation and nystagmoid jerking. A EEG monitoring was done in a C, and 8 to 20% of patients had non-convulsive status epilepticus. Look, the common underlying causes are strokes, subarachnoid hemorrhage, infections, traumatic brain injury, anoxic ischemic, and toxic metabolic conditions. It occurs predominantly that, and drug-induced non-convulsive status occurs in multi-agent chemotherapy and beta-lactam antibiotics, which are given on a background of chronic kidney disease. Therefore, any unexplained alteration in behavior or consciousness warrants an EEG. Don't jump and send the patient for neuroimaging. Order for a portable EEG. And I'll show you an example of that. The second thing that I'd like to tell you is drug-induced seizures and coma. Look at all the antibiotics on the left-hand side. And you see that cephalosporins, carbapenems, and quinolones have a propensity to produce seizures, particularly when the etiology is some neurological illness. Okay? And the risk factors for all that is the elderly patient's renal failure, prior CNS disease like strokes, and the case of metronidazole hepatic failure. But look at cefepime. Cefepime can induce a coma. And if you are not aware of it, your neuroimaging, everything will be the same. Yet the patient lapses into the coma. And this occurs after 1 to 10 days of administration of cefepime, and it takes about 2 to 7 days to resolve. Now let me go fast. This was a lady, 72-year-old with chronic kidney disease. She was on cefotaxime, and she had a sudden alteration in her level of consciousness. We did an EEG which shows non-convulsive status, and given the appropriate treatment, it came back to her baseline EEG. Now, how do you give the prognosis? The prognosis is based on the etiology and severity of the coma, disease condition, the duration and severity, the four reflex activity and motor response, and a combination of all four. Now, the prognosis is usually given on day 1. And good outcomes is if the brainstem reflexes start appearing. If the pupillary reflex is absent and it starts sluggishly reacting to light, you can be hopeful. If reflex movements give place to purposeful or semi-purposeful movements. And lastly, nystagmus. If you do an oculovestibular reflex, initially in the coma, the eyes will deviate to the irrigated ear and they remain fixed there. But if you start getting a nystagmus, means the saccadic component has come through. Therefore, the PPRF and the median longitudinal fasciculus is coming through. So nystagmus is a good prognostic sign. Okay? Poor outcomes, as I mentioned, is brainstem reflexes, flaccidity. And I think nowadays we require EEGs, evoked potentials, and neuronal specific enolays to be done when there is any doubt of some medical legal issues. Lastly, this is my last slide, and we come to the principles of emergent therapy. You all are all aware of all that. I would only ask you to look at point number 8. Please protect the eyes. I've seen many patients emerging from coma and then complaining bitterly of blurred vision because of exposure keratitis. I make it a point to tell the nurses that please put down the upper eyelid with a 3M tape and stick it to the cheek. In the case of Guillain-Barré, with bilateral facial and oculoparesis, I have even done a lateral tarsography and then closed the eye to protect the eyes. So please remember that you have to protect the eyes. All your good results will be vitiated if you don't protect the eyes. Thank you. And I have